Hello guys, this is Joy Bishash back with another video. In this video, we're gonna look at long QT interval. We'll be more focused on MRCP Part 1 examination. Hope this helps, and if these short topic-based videos are more to your liking, please subscribe to this channel. Thank you. So first of all, we need to understand what is a QT interval. We need to go through the basics. We need to understand what is a QT interval. We have to look at a few basic things. This is a P wave, Q wave, R wave, S wave, and T wave. Now, interval generally refers to as start of a wave to the end of another wave. So, in case of QT interval, it should be start of Q wave and end of T wave. Now, as we can see here, Q wave has started from here and it has ended, T wave has ended over here. So the portion in between is known as the QT interval. Now, if it's longer than the normal value, we call it long QT syndrome. Now, you might ask, what is the normal QT interval? In case of males, it is about 430, and in case of females, it is about 450. Now, what is the unit? The unit is millimeter per second. The confusing part is QT interval is also dependent on the heart rate. Let's say if the heart rate is more, then the QT interval should be low, right? So we can generally say heart rate is inversely proportional to QT interval. That is, if a person has low heart rate, his QT interval should be more. If a person's heart rate is more, his QT interval should be less. Now, how do we then determine if it's a standard QT interval? For that, a scientist named Bazet determined a formula, and his formula is QTC. QTC is basically QT interval divided by a root of heart rate. Now, why is QTC important? Now, let's say if a person's heart rate is 150 beats per minute, using the QTC, we can determine if it's more or less compared to the standard QT interval at 72 beats per minute. That's why we measure QT interval in terms of QTC. Causes can be easily remembered using a mnemonic, which is chess match. Now with C, we have congenital. Two kinds of congenital disease usually presents with long QT interval. One is JLN syndrome, which is Jarvell, Lange, Nielsen syndrome, and Romano-Ward syndrome. Now, in MRCP, generally, we might have to differentiate between these two conditions. And the easy way to differentiate between these two conditions is to remember them using a mnemonic also. Here you see, we have Romano. No. No means there will be no hearing problem. But in case of JN syndrome, there will be hearing issues. Now, JNL syndrome is generally caused by two genes, KCNE1 and KCNE2. We need to remember this as well because this is important for MRCP examination. Let us look at the rest of the things. We have completed our C. Then look at H. H refers to as hypothermia. Hypothermia can also cause QT prolongation. And then we have E. E refers to as erythromycin. With S, we have SSRI and sotalol. And with another S, we have subarachnoid hemorrhage. With M, we have methadone. and myocardial infarction. With another M, we have myocarditis. With A, we have amiodarone and anti-arrhythmic drugs. These are generally class 1A antiarrhythmic drugs. With T, we have tricyclic antidepressants. With C, we have chloroquine. And with H, we have 3 electrolytes over here: hypocalcemia, hypomagnesemia, and hypokalemia. With O, we have ondansetron. Now we need to also remember, in case of SSRI, we need to remember an important drug, which is citalopram, because this is very important for the exam. Okay, so we have remembered the causes of long QT syndrome. Then we need to look at the types of QT syndrome. Now, QT syndrome can be divided into 3 types: long QT1, long QT2, and long QT3. Now, QT1 is usually associated with swimming. QT2 is associated with emotional stress, and QT3 is associated with nighttime rest or sleeping. Now, why is long QT syndrome or long QT interval is so important? It is important because this might lead to sudden cardiac arrest, leading to sudden cardiac death. And you might ask, why is that? It is because long QT syndrome is usually caused by defects in alpha subunit of slow delayed rectifier potassium channel, and because of that, a patient might experience VT, which might lead to sudden cardiac arrest. The take away home message is that QT prolongation causes blockage of potassium channel. That is the important thing. It causes blockage of potassium channel. This is very important topic to remember. Now, how will we manage QT prolongation? Now, to manage QT prolongation, we need to first find out if it's a drug-induced QT prolongation or if it's another cases of QT prolongation. If it's a drug-induced QT prolongation, first of all, we need to avoid drug. So the drugs which causes QT prolongation, we need to avoid it. That is very simple. Number 2, we can give beta blocker. Now, the nice recommended beta blocker are generally metoprolol and propranolol and atenolol. Now, you should be careful to always avoid sotalol, because sotalol is one of those drugs which causes QT prolongation. So we should avoid sotalol. Number 3 is ICD, refers to as implantable cardioverter defibrillators. Now, it should be used in high-risk cases. What are the high-risk cases? High-risk cases usually refers to a patient who has a previous history of cardiac arrest. So if a patient comes with a history of cardiac arrest, we should consider ICD. Or if the QTC is more than 500, that is a case of severe QT prolongation. In that case, ICD is the way to go. And if everything fails, the proper treatment is left stellate cardiac ganglionectomy. And we should also check the electrolytes, because as we have known that hypomagnesemia and hypocalcemia can also cause QT prolongation. Now, one thing we should remember is to differentiate torsades de pointes. Now, what is torsades de pointes? Now, generally in an ECG, we must first look at the QT interval. If it's a long QT interval, we must look at the QRS segment. If the QRS segment is wide, that can differentiate into two things. One is VT and one other one is SVT with aberrant conduction. Now, if it's a case of VT, we need to look at if it's polymorphic or monomorphic. Now, in case of long QT syndrome, we generally find polymorphic VT. What is polymorphic VT? Let us look at this ECG. As we can see, the QR segment is wide. So this is a case of VT. Okay, so then we have to remember, we have to look at the structure of the QRS segments. If they're identical, it's a case of monomorphic. If they're not identical to each other, that is, the shapes are different from each other, it's a case of polymorphic SVT, polymorphic VT. So let us look at this ECG segment. As we can see, this is equal to this, but these 4 are not equal to this 4. And let us look at this segment. This segment is definitely not equal to this segment. So it's a clean-cut case of polymorphic VT. Polymorphic VT is referred to as torsades de pointes, and the management of torsades de pointes is magnesium sulfate. We need to give at least 2 gram bolus IV over 1 to 2 minutes if it's a case of torsades de pointes. Another important topic is how will we diagnose QT prolongation. Easily, we have to do a ECG and we have to look at the QTC segment. But is there another way? Another way is Holter ECG monitoring. Holter ECG monitoring is basically a 24-hour ECG monitoring. Okay, so that is what we need to remember for QT prolongation. I hope this video helps you in any way. If you found this video to be helpful, please subscribe to this channel. Thank you.